There are several pioneering, multi-component, mindfulness-based programs that have been designed to help with a wide variety of difficulties, each of which has good research support. And each of these programs offers additional techniques that any of us can use to deepen our mindfulness practice. Mindfulness-based stress reduction was the first of these, and that was started by Jon Kabat-Zinn back in 1979 to treat pain and stress-related disorders. He was a scientist working at the University of Massachusetts Medical School who had had a personal mindfulness practice and thought, these things could really help with such a wide range of physical disorders. Why don't we try to get them into medicine? And it's really his pioneering efforts that are responsible for the wide-scale adoption of mindfulness practices into so many different healthcare settings. It's been the most widely studied and adopted approach, and it's the independent variable in most studies. You've heard me say throughout the course that people were assigned to an 8-week mindfulness training course. More often than not, that training course was simply MBSR, or mindfulness-based stress reduction. It has several components to it, most of which will be familiar to you at this point. Mostly it teaches mindfulness meditation. It encourages informal practice and teaches a number of different formal practices. They use the breath meditation as we have done, the mountain meditation. They also use the body scan, which I mentioned before, where you start at one end of the body and simply use successively other parts of the body as the object of your awareness until you get all the way up to the head and out to the ends of the arms. They also use Hatha Yoga, which is a kind of gentle stretching that can be done mindfully, in which you breathe into the stretch and you simply pay attention mindfully, bring your attention to the sensations of the stretch, and every time the mind wanders, bring it back to the feelings of stretching. Now, when Jon developed MBSR, he had an interesting question. How much practice to ask the participants to do? What he decided on was to ask them to do a fair amount of practice. He asked folks to do 45 minutes to an hour a day, 6 days per week of mixed formal and informal practice. There are also a 6 to 8 hour intensive, a little retreat at week 6, and people attend 8 weekly 2 to 3 hour group sessions. Now, the advantage of making people do or asking people to do more intensive practice is it's more likely that people can actually notice that these practices radically transform the heart and the mind and our everyday experience of living. It's one of the reasons I've been encouraging you to practice throughout the course, because unless you do enough practice to see that these things work, you probably won't get in the habit of doing them regularly. Now, MBSR has been studied more than any other treatment intervention, and many studies document its efficacy for various disorders. The early studies were typically not large-scale or well-controlled, so they'd have people on a wait list, so as I've mentioned before, you couldn't tell whether the results were due to participating in the group, or learning instructions, or actually practicing mindfulness. Increasingly, the studies use active controls, and they have good scientific basis to them. NBSR has shown significant improvement in ratings of pain, other medical symptoms, all sorts of general psychological symptoms, good improvement in generalized anxiety and panic disorder, binge eating disorder improved, improvements in fibromyalgia symptoms. Even psoriasis patients had quicker skin clearing, and cancer patients reported reduced mood disturbance and stress levels during their treatment. Now, one of the programs that grew out of MBSR is mindfulness-based cognitive therapy. And this is one of what we now call the third wave of behavior therapies. Let me explain. Behavior therapy began with the work of Pavlov and his dogs. You probably remember that from Intro Psych, in which he discovered that if you paired an unconditioned stimulus with some other behavior, what would happen is, over time, people would respond to the other behavior as they had responded to the unconditioned stimulus. In other words, you recall the story of the dogs learning to salivate to the ringing of a bell in the same way that they had salivated to meat powder. The second part of behavior therapy in the early days was the work of B.F. Skinner, and this was operant conditioning, or what we call colloquially behavior modification. And this is the idea that by rewarding certain behaviors and not rewarding others, we can change people's behavior patterns. What psychotherapists using behavioral principles discovered was, humans are a little different from animals in that we think a lot. And maybe it would make more sense to start changing our thought patterns and use behavioral learning principles to change those thought patterns. And that ushered in the whole world of cognitive behavior therapy, and there are all sorts of different programs that are designed to basically change irrational, maladaptive thoughts into rational, adaptive ones. The innovation of these third wave of behavior therapies, and MBCT in particular, comes back to the teachings of Carl Rogers, who said acceptance is a precondition of change. And they realized that trying to change thoughts, trying to change behaviors, actually doesn't work as well as first developing profound acceptance of experience. So all of the mindfulness and acceptance-based treatments start with developing this profound acceptance of treatment. The founders of MBCT hypothesized that mindfulness might prevent relapse of major depression episodes. And these folks were cognitive scientists who were studying the thought patterns of people who get seriously depressed. What they discovered was that people who get seriously depressed are different from ordinary people when they're faced with sadness, disappointment, or discouraging news. Ordinary people just feel sad, just feel discouraged when that happens. But folks who have been through serious bouts of depression bring with that all sorts of thoughts that they had the last time they were depressed. This is actually an example of something which is called cue-dependent memory. There are some very clever studies where they took scuba divers and taught them various tasks, things like associating numbers with words, and they taught it to them underwater and on the beach. And depending on where they taught it, people were better able to recall the information if they were back in that setting. So if they were taught underwater, they recalled it better underwater the next time than on the beach, or if they were taught on the beach, they recalled it better on the beach than underwater. We all know this experience from our own simple life events. If you've ever gone back to your old neighborhood where you grew up, or perhaps your college or your high school or your elementary school, suddenly we're flooded with all sorts of memories of that period of our life. Well, the founders of MBCT said this is what's going on with depressed folks, except instead of going underwater or on the beach or back to the old neighborhood, the very mood, the feeling of sadness or discouragement is what brings back the flood of all of the old memories and all the old thoughts. So instead of just feeling sad, people feel worthless, they feel unlovable, they feel rejected, they feel hopeless. What the MBCT founders thought was, if we can help people to see all of these thoughts as simply thoughts arising and passing in the mind, they won't get so stuck in depression. So they taught them formal practice like in MBSR, and all sorts of informal practices like mindfulness of everyday activity. They invented one which is really quite nice for us even if we're in a difficult period, like a depression period, that's called the 3-minute breathing space. And we can do a brief version of that right now. So this is how we do the 3-minute breathing space. We start with awareness. Simply bring yourself into the present moment by deliberately adopting an erect and dignified posture, and if possible, close your eyes, and then ask, what is my experience right now? What's happening in thoughts, in feelings, and in body sensations? What's happening in this moment? And acknowledge and register your experience, even if it's something unwanted. The second step is gathering. Gently redirect your full attention to the breathing, to each in-breath and to each out-breath as they follow one after the other. Your breath can function as a kind of anchor to bring you into the present and help you tune into a state of awareness and stillness. Then we move into expanding. Expand your field of awareness around you, around your breathing, so that it includes a sense of the body as a whole, your posture, your facial expression. The breathing space provides a way to step out of automatic pilot mode and reconnect with the present moment, briefly, no matter what you might be doing. The structure of mindfulness-based cognitive therapy is similar to MBSR, only it's done in groups of up to 12 recovered depressed patients over the course of 8 weeks. They also give daily homework assignments that help people both do their mindfulness practice and to notice what their thought patterns are about. And it uses a mindfulness and acceptance-based approach. Instead of trying to replace irrational or maladaptive thoughts with rational ones, we try to see all thoughts as coming and going and not to be trusted. Mindfulness-based cognitive therapy was one of the first clinical interventions to have a really dramatic outcome, and it's really what put things on the map in terms of being able to apply to major funding organizations like the National Institute of Health or the Institutes for Behavioral Health, and to be able to apply for a grant for mindfulness treatment itself. When they first wrote the grant for mindfulness-based cognitive therapy, it was a grant for attentional control training. After these results, you could write a grant for mindfulness practice. So here's what they found. They followed people over the course of a year, and they found after 1 year that 2/3 of the people who had participated in at least 4 sessions of mindfulness-based cognitive therapy had managed not to relapse. They were depression-free. While the folks who had had treatment as usual, only 1/3 of them remained depression-free. Now, there aren't that many interventions in mental health that'll cut the incidence of something bad, like having a relapse of major depressive disorder, in half. The fact that this could do that made quite a splash and really opened the door to widespread research into the use of mindfulness practices to treat a whole range of different disorders. Now, another form of treatment is called dialectical behavior therapy. And this was developed by Marshall Linehan to treat what's called borderline personality disorder. And borderline personality disorder involves a kind of emotional dysregulation where our moods tend to fluctuate a lot, and in particular, our evaluations of other people fluctuate a lot. So that one day we see people as kind or benevolent, the next day we may see those same people as malevolent, difficult, as our enemy. People with this kind of difficulty have very widely fluctuating moods and very fluctuating interpersonal relationships, and they also have a very high incidence of suicidality, substance abuse, and other sorts of problems. There's an interesting story about Marshall Linehan's work. She's widely known as the founder of dialectical behavior therapy, and one day she approached the Institute of Living in Hartford, which is a private psychiatric hospital, and offered to give a talk for them. She's very famous, DBT is well known, and they thought, yes, absolutely, and they scheduled the event. When she got to the Institute and gave her talk, she explained how when she was an adolescent, she had been hospitalized there for 26 months, essentially with emotional dysregulation difficulties. And what they had tried to do for her didn't really help. And it was because of this that she went on to develop dialectical behavior therapy. She had to find her own way. And what she discovered was mindfulness practice, particularly in the Zen tradition, and cognitive behavior therapy. And she melded these in order to help people with emotional dysregulation. The central dialectic in dialectical behavior therapy is the tension between acceptance and change, realizing that at every moment in our life, when we confront a difficulty, we have to be able to change what we can change and accept that which we can't change. It's basically what's often known as the serenity prayer. People with borderline personality disorders, folks who struggle with this kind of emotional dysregulation, have a heightened sensitivity to all their emotions, and this increased emotional intensity takes a long time to return to baseline. And they often feel their environment, other people, are invalidating because, frankly, these folks are a bit difficult, and other people are often criticizing them and asking them to please cut it out already. So they're used to being rejected a lot, and their emotional displays are met in different ways. Sometimes people respond to them, and other times people just reject them. What Marcia invented was this system of helping people to realize that they could accept themselves, their history, and their current situation, but they could work to change the behaviors that create such difficulty in their environment. And mindfulness practices actually help a lot in doing this. The structure is different from MBSR or MBCT. The structure is usually part of an intensive individual psychotherapy. And mindfulness is also taught in year-long, 2.5-hour weekly groups. And the frequency and intensity of everybody's mindfulness practice is tailored by the individual therapist. The decisions we've talked about before about moving toward safety or moving toward integrating difficult material are helped along by the therapist giving advice. Now, many of the techniques that are used can be useful for any of us. A lot of them are Zen techniques that Thich Nhat Hanh uses. They can be helpful additions to any of our mindfulness practices, even if we're not struggling with some kind of very difficult emotional circumstance. One of them involves the conveyor belt. It's simply sitting in meditation practice and imagining the mind as a conveyor belt with objects moving along it. Ka-chink, 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 clunk. Ka-chink, 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 clunk. Noticing just how impersonal all of these different thoughts are. Another is to see the mind as like a big sky with thoughts passing like clouds, and to actually visualize it that way. One that I find particularly helpful is coordinating the breath with the footsteps. And this helps because in order to coordinate your breath with your footsteps, you have to actually pay attention. So it makes it easier to bring thoughts out of the thought stream and to bring attention into the sensations of walking. Let me demonstrate. I'll narrate what I'm doing, even though normally as we do this, it's done silently. So I'm going to breathe in, out, in, out, in, out, in, out. And what I'm doing as I do that is I'm paying attention both to the sensations of the breath and noticing the sensations of the feet touching the ground. Yet another technique, often done in Zen practice, involves counting the breaths. And there are a number of different ways we can do this. We can simply count all of the in-breaths or count the out-breaths. You can count to 10 and then begin again. One of my favorite practices is to make it into a little bit of a game. Have you ever been volleying with tennis or perhaps playing catch with another person and made a game out of it in which you see how many times can you do it before you drop the ball, before the ball goes out of bounds? You can do the same thing with the breath, only what you do is you count the breaths until you get to the point where the mind has wandered off and left the breath entirely, and then you have to go back to zero again. It can be a little disconcerting at first because you might only get up to 2 or 3, but after a while, the count gets a little bit higher. Again, it's a practice that helps us to focus more when the mind is a little bit more agitated. Another one of her techniques, which I think is very, very interesting, is called willing hands. Okay? Here's how this works. Start with your hands, and you can do this with me now, in a fist. And close your eyes, and breathe a little bit, and squeeze them really tight, and feel what that feels like. Feel whatever emotion is associated with that. And now imagine holding that fist and being really angry at somebody. Feel that anger. Then reverse your hands and open them with the palms upward, and see what happens to the feeling and what happens to the anger. You can try one more posture, which is to reach the hands out in front of you, as though you're going to hug somebody or reach out for help, and see what that feels like. These different postures are what are called in yogic traditions mudras. Different postures that bring out different feelings in the body. And by practicing these, we can see that we can transform stuck feelings into other sorts of feelings. This is one of the reasons when we do loving kindness practice, if you've had a chance to do it in the lecture or hopefully do it also following the audio recordings, we put the hand over the heart. This also changes mood in this way. Another mudra we can try that also comes from dialectical behavior therapy, is adopting a serene half smile. Try this right now. Just allow yourself to smile a bit. And breathe. And notice what you feel inside as you smile. It doesn't take very much to shift our inner experience, just the movement of a few facial muscles. Dialectical behavior therapy also does everyday mindfulness, like cleaning the house, making tea, or bathing, or practicing what Marcia calls Teflon mind, allowing things to come and slide right off the mind. There have been many, many studies showing positive outcomes from DBT. There are improvements in the frequency and the medical risk of parasuicidal behavior. Self-injurious behaviors go down. And treatment retention. People stay in treatment longer when they practice DBT than when they don't. And their illicit drug use, binge eating, all sorts of things improve. Now, another form of treatment is called acceptance and commitment therapy, or ACT. I had mentioned this before. This was developed by Steve Hayes and his colleagues starting in the 1980s into the late 1990s. And he likes to call it ACT rather than ACT because he wants to get across the idea that this is an action-oriented approach. Now, Steve started out as a socially anxious guy. And he's happy to say this. He does it whenever he's giving an introductory talk about ACT. He realized that even though he was highly skilled and schooled in all different forms of behavior therapy, they weren't really working for his social anxiety. He was still having a lot of trouble just meeting new people and talking to them. He decided something else was needed, and he pretty much worked this out on his own. But he wasn't starting from scratch. It's likely that he had been exposed to a number of Eastern meditative traditions, and he used these to develop a mindfulness, acceptance, and value-based psychotherapy. Many of the elements in ACT, or acceptance and commitment therapy, seem to come from EST. You may recall that was Earhart Seminars training, where a guy named Werner Earhart came up with ways to kind of package a lot of meditative techniques in a way that would be very accessible to Western audiences. Now, ACT has several components, many of which we've seen in our own efforts to develop mindfulness. The first is creative hopelessness, and that's about realizing the futility of current efforts to feel better. It also means realizing that the mind simply evolved to create difficulty for itself and accepting that that's the state we're coming in with. It also provides a kind of motivation to try to do something about it. The second component he calls cognitive diffusion or deliteralization. It's his word for realizing that thoughts are really just thoughts, not reality. And people undergoing ACT treatment are constantly reminded in different ways not to trust our thoughts. The third component is acceptance, just allowing experience to be just as it is. And we've seen that throughout the course. The next is self as context. And this is about identifying with the observer of the thoughts, not the thinker. If you had the chance to try the mountain meditation, and I hope that you did that, what happens is we're sitting there as the mountain and we're watching the seasons come and go and all these things change. Instead of identifying with the contents, with the animals coming and going and the snow's coming and leaving, we start to identify with the very process of awareness, with being in awareness and having all of these events happening. That really shifts our relationship to the contents of our minds. It makes it much easier to take them lightly. Finally, and this is pretty much unique to ACT among the mindfulness-based interventions, he pays attention to what he calls valuing, and that involves redirecting one's life to what gives its meaning. And this last one is really interesting. We can try it right now. Remember days in the college dorm room, perhaps, sitting around asking the question, what is the meaning of life? Many people do that when they're adolescents, and they kind of give it up when they get busy with earning a living, perhaps having a marriage or raising children. But it's actually a useful question. What matters to you? What is important? What does it feel like is the meaning for being here? Take a moment to actually answer the question. As you come up with an answer, now ask the question, what's standing in the way of you living your life as though that's what really matters? Because most of us notice when we identify something that we feel is really meaningful, that, we're not actually doing what's really meaningful much of the time. So it becomes a very interesting kind of inquiry that can help to move us in the direction of acting in ways that are consistent with what matters to us. Now, the structure of ACT is usually part of individual psychotherapy, although increasingly it's been done as a group format as well. And it teaches specific ACT skills. There are over 100 of them. And they're mainly based on images or metaphors. They teach insights that you can also derive from mindfulness practice. You remember when we were talking about pain and other kinds of disorders, the idea of the Chinese handcuffs, that when you put your fingers in there, the harder you pull, the tighter they get? That's the kind of image that's used in ACT treatment, and it can be a very helpful reminder not to keep doing the Chinese handcuffs. The outcomes have been very, very promising. ACT is spreading all over the world. You see a lot of it in Europe and Australia. They've reduced rehospitalization of psychotic folks. reduced social anxiety, reduced disability due to pain. It actually beat nicotine replacement for quitting smoking, and reduced high-risk adolescent sexual behavior. Pretty much everything under the sun. Now, we talked before, in talking about neurobiology, about generalized anxiety disorder. That's the problem in which we're not just anxious about a specific thing like snakes or public speaking or going in airplanes, but we're generally frightened. We know that exposure and response prevention is what works generally for a phobia. You recall the treatment of snake phobia in the psychology department. So what do you do if a person is anxious about everything? This is where a treatment called ABBT, acceptance-based behavior therapy, used for generalized anxiety disorder, was developed by a couple of friends of mine, Liz Romer and Sue Orsillo, in the Boston area. And what they do is basically teach mindfulness practice to the patients and ask them to expose themselves to everything that's frightened. Because if you think about it, mindfulness practice is actually experiential approach. It's about embracing whatever comes into consciousness. Now, often when I'm teaching mental health professionals about mindfulness practices, somebody will raise their hand and say, well, what about attention deficit disorder or attention deficit hyperactivity disorder? You're probably familiar with this. This is a relatively recent label given often to children to describe kids who have trouble sitting still and have trouble following what's going on in math class. I was actually at a meeting once where John Kabat-Zinn was addressing a large audience of psychotherapists, and somebody came up to the microphone and said, you know, it seems to me that mindfulness practice is kind of the exact opposite of attention deficit disorder. So might mindfulness practice be useful for treating this? And John replied, somewhat uncharitably, duh, and went on to say, precisely, what we're doing is cultivating the opposite of attention deficit disorder. Now, people who tend to be more ADD, who tend to have more difficulty with concentration, will sometimes say, well, I find mindfulness practice to be difficult because my mind wanders so much. And here's a way to understand that if that happens to be your situation. If I'm a generally anxious guy, and I take a benzodiazepine, something like Ativan or Xanax or Valium, I'll become somewhat less anxious. If I'm already a not so anxious person, and I take one of those tranquilizers, I'll become less anxious still. If I start out as a mellow person and I take one of them, I'll become very mellow. The same is true for mindfulness practices. If we start out with a particularly frisky mind that jumps from thing to thing, and we do a little mindfulness practice, we'll wind up with a somewhat less frisky mind. If we start out with a medium-level mind, we'll wind up with a more focused one. And if we start out with a more focused one, we'll wind up with an even more focused mind at the end. There are studies doing this. One's called the Mindful Awareness Program for ADHD, or MAP, and that's Lydia Zylowska and Susan Smalley at UCLA, and they're doing this with children and adolescents and gathering data indicating that this can be quite helpful. And I mentioned earlier when we talked about self-compassion that there's a mindful self-compassion program that's been evolved by Kristen Neff and Chris Germer. And what they've done is evolved an 8-week program which teaches mindfulness, but the main focus is on loving kindness practices, on Tonglen practices, on all of these practices designed to help people to be able to accept and be loving toward oneself when we ourselves are going through some sort of pain. So in our next lecture, we're going to return to exploring the neurobiological effects of mindfulness meditation, including what we're learning about what happens in the brain when we experience our sense of self and how mindfulness practices can affect that process. Thanks.